Okay, and welcome back. Okay, so now we are going to move into our next presentation, which I think is going to be great. It is transporting of the ECMO patient. And Dr. Samir, you're going to be giving this lecture, and I see you're, I didn't even tell people that you were an assistant professor. I forgot to tell anybody that.
It's okay. I'll cry later, but maybe I'll get over it.
I feel bad now. But anyway, so.
You should.
I do. So, Dr. Samir, transporting the ECMO patient. Teach us something.
Okay. So really, I think I wanted to change the title to ECMO Without Borders. I learned a lot from preparing for this lecture. Especially all of us are familiar with what's going on right now. Between coronavirus, there's no boundary. So we have to think of taking care of these patients without boundaries. And I'm going to go over some methodologies. And thanks to a lot of my friends in Qatar, Australia, for teaching me a lot. And I apologize for the first slide with Joe's picture, a little scary, I know.
Yes, I remember that night.
Joe, you remember this ECLS data? I'm sure you know it very well. Okay, I think this data is going to be blown totally out of the picture by next year with coronavirus and transporting patients across countries, not across states, not to the next county. Now we need to think across countries. You know, our citizens were stuck in Japan. I mean, are you going to leave them there, or are you going to put them on ECMO, bring them here? We have the military doing an amazing job, which I'm sure Joe is familiar, from Landshall in Germany, bringing patients here. So I'll tell you, we need to learn from them, and we need to learn from other people. So I really believe this ECLS data is going to be totally blown out of the water. And survival is going to improve more and more because we learned a lot more. That's what I'm talking about, bringing patients to specialized centers. You can cannulate them wherever you are, get your surgeons to fly there, but bring them to the specialized center for a lot of reasons. We'll talk about that later. So why should we bring patients from a small country hospital to the medical center? It's available, the infrastructure. Yes, we can cannulate the patients. Like Joe knows, every cardiac surgeon can put a venous cannula, arterial cannula, get the patient ready for transport. Joe, would you rather do that or get the patients cannulated by the surgeons of the receiving hospital?
Oh, I would rather. I think that for patient survival, you want to do it where the patient is and then do the transport. I think time is, time is life.
But would you want the surgeons, let's say, from the med center, to fly out to Odessa, or just get the Odessa surgeons to do the cannulation?
Oh, well, I think it would depend on whether the surgeons in Odessa, which I assume they would be able to, could cannulate the patient safely. As long as they're qualified to do it, then I would rather they did it there and got the patient on ECMO and wait, because otherwise that's just going to take way too much time to get the surgeons there to do the cannulation in a place they're not even familiar with. They can get the patient and then recannulate them if they want to later.
I agree 100%. And I think the best setup for this situation would be the transferring center should have an agreement with somebody in the world. This is going to happen, this is a contingency plan. And then the plan should not be like that day. It should be like a plan ongoing for a long time.
Mm-hmm.
You don't have to make up the stuff as you go along. These protocols help a lot. And here's the cannulations. You guys all know that. We're just going for the people who do not know that. Arterial venous oxygenator pump. Now, why is this picture? Here's pits and transfers. Cannulas in the groin slipping out. And I'm sure you've seen that. Patient will be rock stable in the OR or the ICU. You get them on the bus or the helicopter, all of a sudden it's charring. There's not enough volume, we cannot flow. So care has to be paid attention to those cannulas while transferring. Joe, you agree?
I agree 100%, and those cannulas are not the way they should be for being in the ICU. They're not secured in a way that would make me comfortable.
And that's the reason I put this picture on, because I didn't think they were either. And a couple of stitches around the cannulas are not going to keep it from moving. So really they have to be very secured very well. And I assign somebody to hold the cannulas as we're transferring the patient. That's the only way you could, because that person has to move with the patient. Not the patient moves and the cannula is in one another place. And I'm sure you've seen that.
I've seen them pop out.
Yeah.
I've seen it, I mean, literally come out. And it's catastrophic.
Absolutely.
It's not recoverable.
I'll tell you one thing which I learned, and it give me less chest pain. Try to put everything between the patient's legs, because the patient's legs together will hold everything together as everybody is pushing everything together. Neck cannula, same nightmare again. Please pay attention. If any of you have seen a cannula come out, it's like a laser gun shooting out. And then you're going to lose all the blood volume pop by death.
Yes, it's not recoverable, as I said. It just isn't.
So really, I would assign one person to the cannulas, whether it's in the neck or the groin. Something very simple, but we don't do it. And again, I want to see again, as much as everything is going to be stitched, it's going to come out if it wants to come out. And Joe will tell you, if a device wants to come out, it will come out. You just have to pay attention. So, so why are we sending patients out? A specialized center with all the cardiac surgeons, all the protocols, nitric oxide, all kinds of transplant backup, other equipment backup, critical care. That's why we want to send these patients out. And now, another idea has come up to light recently. If you cannot send these patients out, you should consider like having a tele-ECMO program in your institution.
Absolutely, I agree with that 100%. And and that is something I think that is going to have to be done for a variety of reasons. One, I think that it raises significantly the level of care that a patient's going to receive, but it does so at the same time as reducing dramatically the cost of providing this service. There are hospitals that do not provide ECMO because they know how much it's going to cost, and they can't pick and choose, so they don't have it at all. And that's a big problem.
And I think really telemedicine is the way of the future. So having tele-ECMO is the same concept as tele-ICU. You can have a board-certified critical care physician, which the nurses can call and get consultations from. The other physicians can get consultations, provide support for the hospital. It will be available 24/7. When the physician can come in and take a look at the patient, take a look at the equipment, adjust flows, adjust oxygenation.
And that can be run by, I don't mean to interrupt you, but that can actually be a situation where, and I'm not trying to kick my colleagues to the curb here, but cost is a big issue, and even staffing is a big issue. If you don't have enough perfusionists to sit around the clock and still operate, you have to make a decision. Are we going to shut our heart program down because we have an ECMO, or are we going to find another solution? And I think the ECMO specialist model with a telemedicine certified ECMO physician, critical care medicine physician, can make the decision and say, call the perfusionist if it's something you think needs an intervention that a perfusionist should do. But it relieves the perfusionist of that 24/7 burden being at the bedside, where they can be available for doing the bypass for the hearts.
Absolutely.
That's what I think anyway.
And again, this is what's currently happening in a lot of the hospitals for ICU, and it should go to ECMO, because you want to have the expertise, which is not available immediately in a lot of hospitals. You have that expertise, and you can call them in and consult with them. Again, more of why we should transport patients. Now, this is a paper, a very interesting paper. And I'll let Joe.
Dr. Noon, oh my God, Dr. LaFuente.
See, I surprised you with this paper.
George Noon, man, I'd heard that name in a long time.
And
is he still alive?
Dr. Noon, yes, sir.
He is?
And he looks great, and I see him every other morning having coffee in the hospital. It's amazing.
Well, don't tell him I asked that question.
He's an amazing gentleman. And Dr. LaFuente is the primary cardiac surgeon from Methodist Katy, and he is a great friend and a great person. And he worked a lot with Dr. Noon to develop transplant, VADs, and biomedicals, which I think we forget to talk about. Because biomedicals is how everything started. Do you agree or no?
Agreed.
Yeah.
Totally agree.
Yeah. So biomedicals, and still right now is one of the, correct me if I'm wrong, the cheapest pump.
Is it the cheapest pump? No, Medtronic owns it now.
Okay, so it's not cheap anymore?
Oh, no. No.
They took it, relabeled it?
Medtronic owns it.
Repackaged it?
Yeah.
Okay. But back in the day, are you going to agree that Biomedicus was the cheapest?
Well, for the longest time, it was the only centrifugal pump option. So, you know, I think that it had, because of that, a lot of market share. And yes, it was the more inexpensive of the models. But then, you know, other companies started building them, and they got smaller and all that kind of thing. Less prime volume and fancier, less heat generation in the bearings. And of course, you know, then it sort of distributed itself out. But Medtronic has come up with a lot. I cannot believe you put perfusion.com on here, of all things. I cannot believe you used this picture. That's killing me.
I'm sorry.
I can't believe you did that. You
Okay,
need.
it's hurting
mean,
you? Okay, you can call your friend Roxanne and let you go talk to
I
her
mean,
later.
okay, yes, I do. I
Yeah,
need to
shout
talk
out
to
to
Roxanne.
Roxanne.
This is
It's her
horrible. But anyway, with that said, I think that now it's, you know, I would say competitive. They're competitive, but it's not the cheapest anymore.
But remember why Biomedicus was successful for a long time? Because Biomedicus was the component for the heart-lung machine. And if somebody needed to go on a VAD, they just took part of it.
Correct.
And that was the easy part.
Correct.
Can you tell me a little about what you feel about transporting patients with Biomedicus?
It's cumbersome. It's difficult. It's a little bit bulky, and you know, there are other tools that are perhaps a little easier. But of course, I've seen these put on different carts, and yeah, there's all sorts of iterations of these things.
Well, to be honest with you, a lot of institutions say have a Biomedicus setup primed for an RVET support just in the closet. Again.
Well, yes, I think they have that, or they have whatever version they use. So you can do RVAD support with, of course, you can, you know, there are Impella, the Impella RP, a little difficult to get in. There's the Levanova, the old tandem heart, what is that called? The Protect Duo, which is a RV bypass, you know, catheter, goes into the pulmonary artery.
But I mean, you cannot come off pump. You cannot
but
come off pump. You can
yeah,
just
you can
have
use
this
any
with the
centrifugal
closet,
pump,
exact.
though, not necessarily the Biomedics. We don't,
I
only
mean, the reason
the
because it
old
was cheap
guys.
exactly, the old guy, because it was cheap at the time.
Right. The old guys call it get the Biomedicus, but we just now say get the ECMO. We're going to go, you know, on ECMO.
Well, I'm glad Joe started informing the controversy, because we have a lot of controversial stuff coming up.
Well, this couldn't be any more controversial with that slide. So if you could just get off that slide, I'll be a lot happier.
Well, maybe I should agitate you and keep going back to that slide.
Don't.
Here's the controller for the Biomedicus, Joe's favorite.
Yeah, weight 55 pounds.
No,
And that's because it has a battery.
No, it is very cumbersome. I have to say that. But one thing I'll tell you, there's a program, or there was a meeting for transplant that says every transplant program has to have an ECLS program protocol. And the ones that were
You mean an ECPR?
no
Or ECLS? Okay.
Yes. Basically put the patient on pump.
Right,
You
okay.
have a transplant. You code. You go on pump. No pondering. No journal club. And so do you agree on that?
If you have a cardiac arrest
And you had a transplant, like
and
let's say
you
a week
had a transplant, oh yeah, I agree with that. Sure.
And so that's why I
It
think
buys you time. It's basically a bridge to decision. What the hell happened here? Is it reversible? And what are we going to do? But in the meantime, if you do all of that, as you said, hand wringing and polite contemplation and debate, the patient's going to be gone.
I have to tell you, I'm agreeing with that a lot. And then the controversy, do you know how many of our institutions have that in place? Without pondering. The ones with pondering, all of them. Without pondering, automatic, how many do have that in place?
I don't know.
Zero. Okay.
That's unfortunate. I think that surprises me.
There is an institution in a country far, far away from here that automatically, you got to transplant your code, you're going to be going on pump. The Australians, who are amazing in advanced in medicine, if you had a transplant and you code, they do not call the code team, they call the ECLS team. The ECLS team comes with a cart that has a saw. They will zip your chest wide open and put you on central.
Wow.
Yeah.
That's the best cannulation.
Absolutely.
There's no question about that.
And these guys, I have to tell you, I mean, I looked at their stuff, they're amazing, their numbers are amazing. They'll come, zip your chest open, bedside, put you on pump. People think that's too violent. Joe has seen, I've seen, opening chest bedside, it's not that bad at all. You know, I'll tell you, if you have experienced surgeons with experienced nurses, it's going to go very smoothly. Do you agree?
I agree 100%.
I mean, really, if you don't panic, just get it done and get it done immediately. Don't ponder the situation. If the patient is purple, by the time you do that, you're doing a very bad job.
Well, a lot of that, you know, time, look, I mean, we see it on the battlefield, right? They have the golden hour. From injury on the battlefield to the soldier gets to the field hospital. That every minute that goes by, if you can get them within an hour, their chances of survival are much higher.
Absolutely.
If you can restore good circulation more quickly, it just is commonsensical almost to me, even though I think that you can probably have some pretty good CPR under the right circumstances with the right people and the right patient. There are always going to be some obstacles to really good CPR. But you can't beat putting the patient on artificial circulation and oxygenation, and it's a done deal. Now you know you're getting good perfusion. And now the rest of the body has an opportunity to survive, a much better opportunity.
I'll tell you, and I feel that's for any transplant patient, MCS patient, that's a solution. Ponder what went wrong, like Joe said. And at that point, I wish our pumps had continuous lactate reading.
Oh, I wish they did too.
I mean,
I just wish we would check them. We don't even routinely check them.
I think if they were continuous reading, Joe would be like the hemoglobin. You would really be following that and trending it.
Yes, and that's what you should base your flow on.
Absolutely. Because the first lactate reading from somebody who just coded would be like crazy. I want to see a washout and follow it.
Now, I think, of course, now you'll probably help. If I can I be as controversial as you?
Oh, please fire away. I'm ready.
I think if a patient is in that kind of a situation, they're in extremis, they've coded, they've been crashed onto bypass, they have a grossly elevated lactate, I believe that patient should immediately have, once they get to a facility, not in the field, but a facility, immediately put them on CRRT integrated into the ECMO circuit to normalize everything and remove those metabolites like lactate and also correct their
I'm
acid
100%
base.
believer of that. You need to go on CRT and wash all the,
Because if you have to depend on the kidneys to do it, you know, the kidneys may be compromised, they might be
Don't
injured.
wait for urine. Do not wait for anything. Absolutely.
Why do people do that though? All the time.
I don't know, because they're
Even if
scared.
you have urine, because you know, we're not doing it for. If that case, you're not doing it for fluid removal. I know the kidney will do it, but we're asking a kidney that has been insulted to work even harder than it normally does. It just doesn't make sense to me. But I have this argument with people all the time.
I think
Nephrologists
CRT
just
should
disagree
be
with
part
me.
of the recovery, like a vent, ECMO, CRT.
I agree. Okay. I agree.
We agree today. That's at least shocking. Okay, now we're going to look at more stuff now. And John, I want you to comment right away on everything that you like or you don't like.
Okay.
Okay, what do you think of the Centra Mag by Thoratec for emergency ECMO and transporting, remember?
I think it's for that purpose. It's incredibly expensive and unnecessary for the short term. And that, when I say short term, I mean up to probably 2 weeks, maybe even longer with today's pumps. It's a very expensive pump. Now, if you're going to be on it for months, I would say that's definitely the one that you would want to use.
How about it can flow up to 10 liters? And you know, we live in Texas, people are very petite here. And
Well, the restriction is going to be the cannula size. There's very few cannulas, there's very few people's arteries big enough to flow 10 liters because it's dependent on the size of the orifice of the cannula, the length of the tubing. All of those things are going to contribute to the resistance to flow and therefore the line pressures. And of course, you're going to have increased shear forces, so you'll get, you know, more plasma-free hemoglobin or hemolysis secondary to it. I think it's a good pump for the very long term. For short term, I think it's overkill and way too expensive.
And how about you don't feel like compactness pays for it? That it's so compact?
No.
Okay. Here's the console, easy to manage, to be honest. It's very also light. You have to admit that.
I think
And the
that-
long battery life.
I think that pump is a very good pump for air transport. I think that, again, it's comparatively very, very expensive. The circuit for each one of that box is somewhere between $120,000 and $140,000 in that range. And the circuits for them range between 12 and 14,000 per circuit, whereas a normal circuit with the same type of fiber that they have, which is a longer durability fiber, is about 1,800 to 2,000. So there's a big difference in cost. And so I think that's something that you have to take into consideration. Now, if you're going by helicopter, you're going by fixed wing, I think that is that is a must-have. That is a must-have. But if you're a community-based hospital where you don't do that many of these, you're not typically going to transport the patient somewhere. They're going to come get the patient.
Absolutely.
They'll bring their own system, they'll convert to theirs, and then they'll go. And converting is not, it's never fun, but it's done, routinely and safely.
So I have to ask you, when you talk about your system, you have to let the audience know what is your system.
Well, we use the LivaNova platform, and it's decent size. It's not real small, but you can remove the battery and the control and get it between the patient's legs, so taking it on ambulance is pretty easy. So we use the LivaNova system. I think it's the S3 they call it, and it's a platform where it has a cart so you can move the patient to, let's say, CT or somewhere else in the hospital you need to take them to cath lab or whatever it may be. So it has some portability to it, but it would not be appropriate for any type of air transport.
Why?
You really have to. Too big.
Too big, okay.
It's too big. It's too big and cumbersome. Yeah. That's a very simple, that's what that was made for.
And what's the cost of your system around?
For the whole platform?
Yes.
The whole platform
With
maybe.
with cannulas and everything.
Well, for the whole for the hardware that you have to have like that, a pump and a battery and all that stuff, that's running about 50 to 60,000, and then the circuit, depending on whether you use polypropylene fibers, which are more for short term, or you're using polymethylpentene fibers, which is more for the long term. They have like about 30-day durability, plus or minus, just like the one from this company does. That's about 1,800 to 2,000. The polypropylene one is about 1,000, whereas this is 13,000. That's a big difference in cost. And if you're a community hospital, you have to take that into consideration. Do you need it? Do you have to have this if you're going to keep the patient? And if the patient is going to be taken via transport, you're going to drive them there, that platform will work very well and very simply. If they're going to come get the patient with the helicopter, they're always going to bring their own system anyway. So it doesn't make any sense. Because when you take them to the receiving facility, even by air ambulance, we have to take that equipment back. So we have to convert them over to their system anyway, regardless of what system they're using. Because the tubing stays the same.
Absolutely.
It's the
slice connector.
Right, correct. That's fairly universal.
Okay, I'll tell you, I love the Central Mag for one reason. I enjoyed riding the trains in Japan. Central Mag was developed like with the Japanese train idea in mind. If we can get that video going, it'd be great. Which is basically no touch policy of the rotator on the device itself. And it's just by magnetic levitation forces. That's how the train in Japan was designed, and that's how the design of the company made. I believe in thrombotic events during ECMO and bypass causes very catastrophic events. That's what we used to call pump head. That's not pump head. That's thrombotic events happening during bypass.
You think?
To be honest with you, I do feel that. And if you do continuous TCD, you see it. And one of our friends loves TCDs.
And you think it's thrombotic?
Yes, like embolic thrombotic events. Things flying away from shear forces.
From the aorta?
From the water, from blood contact with the pump.
You really believe that?
I do believe that. I'm not gonna lie to you. And that's why. Do we have the video with the low touch? I don't think we have that video. But there's a video that shows how the speed goes very fast. Maybe that's it. And it doesn't really touch, the bearings don't touch each other.
Right. It's magnetically
Yes.
levitated. Right.
And that's, I mean, again, I keep promoting that, and I'm
And
not
that's
Japan.
that's a heat generation
Yeah,
thing.
I'm
It
not
prevents that.
Japanese, but the train in Japan slides the weight that fast. Because there's no touch, the friction slows the train. And that's why I looked at that train and I learned from that the friction from the blood with the bearings must cause a lot of thrombotic events. TCDs, Joe. Should I report you to your friend?
Go ahead.
TCD.
Now, I believe in TCD.
Well, what's TCD showing you? Showing you these little flicks coming up from here.
But they can't, TCD doesn't know, I don't think so. I don't think TCD can at least what I remember Dr. Garami telling me, is that it cannot selectively determine if it is particulate or gaseous. It's only seeing something.
I agree with that, but the question is, like, we have decided we're not going to have journal clubs. I don't want a journal club. I don't want particular. I'm really afraid of the thrombotic embolic events. I'm scared of it. And I'll tell you, I'm starting to see it on balloon pumps. I'm starting to hate balloon pumps because of that. Every time the pump pulsates, you see the rush.
You have to anticoagulate the patient.
We stopped anticoagulating balloon pump patients in 1920.
Okay,
Why we have to say
can we
that?
see this thing spinning around real fast? While you're doing that, I've got to do something. I've got to do one thing. So just keep talking. I'm watching.
Okay, sir. Okay, we can stop the video. Go to the next slide. Are we able to? Yeah, okay. Now, look at this system. Did you like the PLS system by Maquette?
I mean, it's okay. You know, it's okay. I mean, I have an issue with a square oxygenator. I don't know anybody's blood vessels that are square.
I think maybe you. You might be square.
No, mine are round.
Are you sure?
I swear. So, you know, a square oxygenator to me, and from an engineering perspective, just doesn't make any sense. And if you study these oxygenators, you find that the corners, not unexpectedly, have very routine areas of stasis and stagnation. And that's where you're going to have increased thrombogenicity because of that lack of flow. And then you will have that problem of your oxygenator starting to fill with clot and then flaking them off into the through the arterial system. So I just don't think a square oxygenator makes sense.
Okay, I tell you why I don't like the system, and you're gonna make fun of me. I feel like somebody's gonna kick that oxygenator, is gonna fly off, and the system is gonna fall apart. Okay?
That's the least of the problems.
I don't know. For some reason, it's in my imagination. That's what's gonna happen. That's what I'm gonna say.
Now I can be somewhat clumsy. If we do your case, you're probably best to keep me out of the room so I don't trip, because I could trip and fall. That could happen if they're using this one.
Okay. Absolutely. But this one, I don't really like it. I
don't like it for other reasons.
No.
But it's a good ox. I mean, it does work. It's FDA approved.
A lot of things the FDA approved I don't agree with, but anyway. Do you agree for this is why send the patient out? And what kind of system to use? Would you agree with these points?
What am I saying? Inlet suction pressure, management of, okay, wide transport, outlet pressure. I don't understand the
No.
power
I mean,
failure.
how to manage the pump during transports.
Well, you do have to worry about obviously your access. You want to make sure you have good flow. It's not collapsing around the vessel. Fluid balance is good. You don't want over resistance to flow where your cannula may be up against the wall of the artery or whatever the case may be if you're VA. Power failure is a huge concern, but you have a hand crank, so you know you can do that.
Can I ask you, how many perfusionists know how to hand crank?
I mean, we all do.
I think
everybody does.
The more experienced ones are very good at it because they've dealt with it.
That may be true, but I would say I would say the overwhelming majority of perfusionists, if they would be able to hand crank. It's not a complicated maneuver. It's pretty simple. And they even make them now so you can't turn them the wrong direction. It will only go one way.
No comments. Yeah, I was going to say that, but you're the one who said it.
Yes. Check what? My phone?
Yeah.
Should we stop? No, okay, so I'll tell you why I put the slide on. It's a segue for my next slides. I mean, why send the patient out, you know? And how to send them out safely. You have to worry about if you can have blood in the bus or in the transport vehicle. Do you have CO2 clearance? How you manage all that? Blood thinners, how you're gonna monitor the patient, power backup. And so I really could get concerned about safety a lot. The last time I sent a patient out, and I'm not gonna name the hospitals, I made sure to send a critical care nurse and a CRNA with the patient in the bus. And that worked out very safely. And that became our standard of transfer.
With the perfusionist.
Absolutely.
Yeah. Or on ECMO.
Well, the perfusion is like, there's no even mention, it has to be there.
Yes.
Yeah.
Well, unless it's a specialist model.
No,
They
I'll
have
tell you,
done
I
it.
would be comfortable with this situation. I would have to say, I need a perfusionist.
You think a perfusionist? Okay,
Yes,
I think
critical
that's
care
fair.
nurse and a CRNA. And that worked out perfectly. It became our standard after that. So this is the slide, the segue of a lot of other slides. See, how to manage ECMO, I mean, everybody knows that here. And who transports, we already covered that. Now, this is here we start the controversy or why I ask all these questions. So, talk about ECMO and cumbersome. Poor Joe is in the ambulance over trying to get in the corner, squeeze the equipment and the patient. You have to remember, you need the patient on the bus, you need the people, you need the equipment. And sometimes it's not an easy task. You agree, boss?
I agree. Now, in fairness, that top right picture of me, okay, I look pretty good in there, though. You know what? I look
Amazing.
good.
Like
I
you're
do. I look
really
good.
like amazing.
I didn't know I was that good looking. But that was before
You lost
I
weight?
realized. No, before I realized that we could take all of that apart and do it like you see on the bottom picture, where I'm now sitting with Min and an ICU nurse, Archie, having a nice, easy drive instead of that craziness, because I figured out I could take that platform that I was talking about and put it down between the patient's legs, and it made it very easy to do. So, you know, you live and you learn, right?
Absolutely. Now, this was ground, the helicopter. I mean, I'll tell you, helicopter is not the easiest thing for transfer. Do you agree?
Agree.
There's not much room there.
Very hard to do.
And if you ever went on a helicopter ride, you realize that. Unfortunately, I had the luck of going on a helicopter ride as a physician and as a patient. There's not much room. I mean, I was trying to look downstairs at the road, and the paramedic says, Dr. Samir, what the hell are you looking at? And now, this is from one of my friends in Hamad Medical Corporation in Qatar, a Learjet, which is converted to an amazing transport vehicle. And I'm going to look at it. We've got to be proud of other people, what they do. We are advanced. I do feel other people are more advanced than we are. They have the capabilities that we think we all have, but I'll tell you, I'm very proud of their work. They do amazing work. They also have a great ECLS program. You code, you get cannulated. No playing around. And we're going to show some of those pictures. This how the ramp, and we can play those videos whenever we're ready, as we come to that. This is the loading ramp, how to get the patient, and they adapted the plane like that to load the patients smoothly, no issues, no patient, like nobody hurting themselves, and the patient got in smoothly. And I'll tell you, when you look at it, this patient sliding in with all these people on the bottom, and they have a harmonious team. They drill it about a few times a year. And they do ECMO without borders. They transfer between different countries, not in different regions. So you can call them from one of the countries. I have a patient needs to come to you guys. They will send the Learjet with the team, and we'll look at the team later. And it's an amazing job they do. Again, this is not my own institution. This is a friend who has shared these videos with me, and I really appreciate Dr. Ibrahim. He's a giant. And there's a meeting right now in South Africa where all this data being presented in.
Yeah, you told me about him.
Yes.
In fact, we've been
was
trying to get him on the program.
Today he's presenting in South Africa, which I like you, Joe. I wish I was there with him, okay?
But he can he can be in South Africa because we have the technology to do it with Skype, and he can come in and we can feed him, and he could have been here with us.
And he's presenting unfortunately right now. And this was a patient who was transferred from Sudan to Qatar. And if you look at the geography, Sudan and Qatar are not that close. And so I'll show you how that plane is equipped. And I'm not a manufacturer or a speaker for the company. I'm just showing you how this plane is equipped, and they made it like a little hospital. So the thought that went behind it, all about the safe things we talk about, went through that. And I think that what has it, we have it here in the U.S. more, is the U.S. military is amazing at those kind of transfer from land shoal. And I'm sure you've seen that, Joe.
Yes.
So, I mean, this is a much smaller scale, and the civilian from different countries. And you just think, like, I mean, should we send a plane to Canada to pick up a patient? It's something, and Canada is much closer to us. Sudan is not close at all to Qatar.
No, and I think we're going to see more and more of that, I think, as time goes on.
Absolutely. Coronavirus, all these people stuck on the ship. I mean, you need to evacuate them to a center that can handle that can handle ECMO patients on a vent, manage them critical care physicians.
I mean, there was 2 of them that died. They got diagnosed.
Absolutely.
They were on the ship, and they ended up dying.
The problem is, not one country is going to have enough equipment to put these patients on ECMO. I'm sure Joe remembers during the SARS time. Everybody here was freaking out. What most hospitals did, they took pumps apart, and they had to decrease their cardiac surgery cases.
H1N1 too.
Absolutely.
That was the big issue. And no, we were actually, we were called out here for diversion from the med center. They couldn't take any more patients. They were so overloaded, and they were filtering them out here.
Absolutely. And there was a backup plan to have one of the hospitals out here, like the H1N1 hospital. Again, I may look at the pump, like Joe said, between the patient's legs safely. I'm learning a lot from them. They have a track that they roll the patient there. I mean, there was a lot of thought that went into this situation. We're not talking about how fancy the plane is. We'll talk about that later. We'll see the launch for the doctors. Finally, the doctors are getting appreciated. So I'll tell you, and they're loading the patient with the bed into the Leo. Remember, this is not a C-130 carrier. This is a Learjet.
Mm-hmm.
So I mean,
yeah, so set up like a pretty good size ambulance. I mean, that's
exactly.
That is a.
And they encourage the family to come with the patient, and I mean, they actually to bring the family with the patient. The family was very gracious enough to agree for us to televise these videos. So I want to thank the families. I want to thank Dr. Ibrahim again. And I would just want to show you, hopefully it will come a little later, the outlets of the wall, the immature oxygen, electric. So you want to say, Joe, which system they used? I'm not going to let you say it. Here.
Which system to use in this case?
No, they used.
Oh, I think what they're using is an appropriate system for what they're doing.
Absolutely. So
it's the
we
smallest.
agree there?
It's very, of course. I mean, I think that it has excellent utility in this setting. It's the right thing to do,
So
even if it's a square oxygenator. But regardless of that, the platform is designed for this purpose.
And even with that, they put the pump, they put the console and everything between the patient's legs. The safest way, I learned that, because you can always hold the patient's legs together, and they would hold everything together.
Mm-hmm.
And I'll tell you again, this was a VV ECMO, you know, again, and they said that they took the patient and they're transferring him. I just want to show a little more. Hopefully, you can advance the video a little more. Here's what I wanted to show. Outlets in the wall for everything. Okay, that's
Oxygen, air.
everything. Electric, oxygen, air, what we talked about.
Everything. Yes.
Everything. And then there's another side, is computers for the physician to document even in flight. Okay, I mean, that's amazing to me. I have to say that.
Why don't we have this?
We can update your wings.
Yeah, my airplane. Yeah, okay.
Absolutely. Look, again, I'll tell you why we don't have that, Joe. You can ask that controversy. I don't want to. I
Yeah,
don't
why
wanna get in
don't
trouble.
we? Why don't we
And
have
here's
it?
the Dr.
Oh, there's
Ibrahim,
Dr. Ibrahim.
and I want to thank him. They have a
Ibrahim.
little, yeah, Ibrahim. And he's a little lounge for the doctors, so the doctors don't have to suffer through this flight. They can get something to eat and relax while the patient is being transferred. And they're keeping an eye on the patient. And I think that's the right way to do things, to be honest with you. We have to appreciate and respect our medical personnel. And so I'll tell you, really, this made me feel ECMO without borders. We can do this anywhere. And if they had telemonitoring, maybe they could have watched the patient over Sudan, but Sudan had no capability of taking care of this patient. So they asked the patient to be flown out.
Now, this is where it gets tricky. For example, and it's a harsh reality. Well, let me let you finish, and let me let you finish because.
Well,
I
here's
think,
the advantage of transporting, and you can comment right there. You have board certified critical care physicians they're going to. They have CVHD, which is their ECLS
very
team.
important. Very important.
ECLS team, which knows how to manage the situation. Guidelines, which is very important. Anticoagulation, which we really haven't talked about that much. I'm a big believer in, especially in these long journeys, give a bolus of heparin before you leave. And then if you're flowing high enough, you really don't have to be crazy about the anticoagulation level. Do you agree or no? If you're flowing high enough.
Yeah, if you're flowing high enough, but I don't necessarily think I like the idea of giving them a big bolus because
No, not a big bolus. I'm talking about 5,000 units.
I don't think that's enough. If it's, I don't
Come
think
on
that's
now,
enough.
make up your mind, Joe. Enough
No,
or
I'd
not
rather
gonna-
just put them on a drip. I'd rather give them 5,000 bolus and then put them on a drip of, let's say, 1,000 an hour.
Okay.
That's what I would do. How long is the flight?
This flight is a 5-6 hour flight.
Yeah, I'd put them on a drip.
so-
I would give them a bolus of 5,000, maybe even 10,000, and then 1,000 an hour, depending on the
If
weight
you're
of the
flowing
patient.
5-6 liters, you're not confident?
No.
Okay, I'm gonna have a couple of my surgeons find you. A couple of the one from New York, one from Florida. I'll have
Okay.
them find you. Now, one term I learned here, which I'm not sure if you've seen that term before, ECMO circuit emergency response team. You like that term?
I do. I like it.
Me
Is that,
too.
is that a new one? Did you come up with it?
No, sir.
No.
No, I'm not that smart. I promise you.
ECMO circuit emergency response.
Yeah.
So that would be a specialist model, but you have somebody who is overseeing everything, and when there's a problem, he or she is on that team.
Absolutely. Or basically, I think the critical care physician, if there's a problem, should call the response team and escalate as further needed to the surgeons if that's needed. To
Right. So it could be a circuit issue where the oxygenator's failing, needs to be changed immediately, to a question of why are we having shattering in the line and access issues.
Where's the
to
cannula?
whatever.
Cannula
Is it a
response?
cannula position? That would be a surgeon. Then you'd have to escalate it up from there, right?
And again, why are we sending patients out nitric oxide? We forget about nitric oxide.
You know how many hospitals don't have nitric oxide?
But can I tell you something? Do you know
Do you know how
there's
many don't have it?
I'm not going to name the company. There's a new company for nitric oxide, which is totally different, cheaper than before. And they actually have contracts where you can use as much as you want, same price. So that is good. That's pretty
I think that, as long as we've been talking about nitric oxide and the benefits of it, especially for pulmonary hypertension, RV failure, this kind of thing, as much as we talk about it for years and years and years and years, that it's not ubiquitous.
I want to inhale nitric oxide on the side. I think it's going to be good for my lungs. But I'll tell you, I think right now nitric is it's a big deal, and you should transfer your patient to an ECMO center which has nitric.
I agree.
Yeah.
You can maybe get them weaned off of ECMO, which would be much better.
Absolutely. Now we also have to talk about the safety risk, and you have to really do this every day. You cannot do it once in a lifetime, and that's it. The transport vehicles available, and I'll tell you, in the city of Houston, and Joe knows, there's not many transport vehicles available that can handle that situation. And it's a drama when Joe wants to transfer a patient from one place to the other.
We have to tell them, bring the big bus.
Exactly.
Do not bring some little ambulance. You got to bring the big one, the big box.
And, climate issues, obviously, fly or ground, that's always a controversy in transplant or these kind of situations. International transfer, I said ECMO without boundaries. We have to forget about boundaries. We're here to help patients. Political issues, drama issues, that's not the issue. Take care of the patient. I really want to thank everyone, and I want you to realize that I think ECMO across borders is the thing for us. We should not be limited where you are. Let's say if you're visiting a country and you're on vacation, you drop dead. Do you want us to save you or leave with you because you're in a different country? You have to think about yourself. We're making rules and regulations. So when politicians are making rules and drawing lines, they have to think about that.
Yes, I would agree with that too. I think that's absolutely true. So let's become controversial. We can open the
As
phone
usual.
lines too if you want. So you want to open the phones, David? Thanks, bud. So I think the ECMO without international borders makes sense. And I think there's a lot of people, let's just say hypothetically in the Bahamas, possibly down in the, further down in the Caribbean, Central America, that would benefit tremendously from being able to be brought here to the United States and treated here. But of course, are we talking about our citizens who are insured, who need to be repatriated for this care? Do they have that expertise there to at least get it started? And then, of course, if you have a patient who, so cost is an issue. It can't be avoided. We may as well have the discussion. And that sounds, unfortunately, it sounds inhumane, but it is a harsh reality of the world we live in. It doesn't matter where you are. It's the same problem everywhere. Canada is not going to just start taking people from another country because they have the capability, because they would bankrupt the country. So that's a problem. And then knowing, whether or not the patient, let's say, was they had a cardiac arrest. Was the CPR good? Is this patient viable? Did they have enough brain protection? You have to check. You have to have a neuroconsult before you bring any patient under any circumstances from wherever they are to here. You have to determine the patient's viability before you accept a transfer like that.
I'll tell you what I feel about that, and we have done that. I would say do a virtual. Now everything for me is about virtual. Do a virtual medical review board. And the medical review board, as somebody from every discipline, goes through everything. So you have to look at a virtual medical review board that you can do on FaceTime if you don't have the capability. So you can do that and discuss and decide to accept the patient or not. I do feel that all the hospitals in some of these countries are able to put patients on ECMO, but are not able to do with them whatever. Like this patient was put on ECMO before arrival. They did not go put him on ECMO.
Right.
So the patient's on ECMO already. The question is, could they handle that? They don't have the capabilities. They don't have an exit strategy. They don't have MCS. They don't have CVHD. They don't have ventilator expertise from critical care physician. So I think, there has to be a program where the physicians here can manage those patients pre-transfer, get them optimized as much as they can for the ride, and then come to a center where there can be an exit strategy. But the evaluation of this patient should be done with a virtual MRB, so like any other patient will be done here.
Yeah, I would agree. I think you have to do that. So, and being cautious to not say too much, but enough. We're very fortunate where we are out here in this community. So we're in the northern Houston area. We have ECMO capability at all of the hospitals, but not far from here, not far, they have no capability of providing that. And for patients, and I know hospitals in other states where there's not an ECMO center within 200 miles. So when you end up in that hospital, it almost becomes just simply the luck of the draw. Did you, by happenstance, end up at a place that can do this and has that expertise? And should it be, again, kind of like going back to the nitric oxide thing, should it be a requirement that a hospital be able to put it, when I say a hospital that would have the appropriate, like, you're not going to take a cardiac arrest patient to a surgery center. Everybody knows that. But if you have an active emergency room that sees patients that come in with ACS, for example, that you should have emergency ECLS capability. Should that be a requirement?
I'll tell you, that I don't agree with should be a requirement. But I think right now we fly all over the place to get organs. Some of these places where you get organs are small hospitals. We should be able to fly our ECMO teams to these hospitals, put the patient on ECMO, and then bring him to our own center.
But what if they come in? What if they come in PEA?
That's what
They're going to do CPR on them until we can get there?
No,
Probably not.
Probably not. And that's what you have. If you have that, then there's death. We have to accept death at some point.
But that's by virtue of going. That's the difference in the ambulance turning right and turning left. That's the issue. That's the problem that I have.
But can I ask you something?
Is the patient doesn't know. Or
Does
the
every
family
patient,
doesn't
does
know.
every patient coming in PA in a big medical center going to go on ECMO?
No,
No.
if it's
gonna
appropriate.
It's going to be a decision made virtually.
But they still have the ability to make the decision. It's not my point.
I understand, but
You
unfortunately.
hate it when I do that. See,
No, but there's
the
some
way
things.
the way I think is everybody should have this. I think that way. Now,
See, I think
it's
mandates are
unrealistic
it's not
financially.
realistic. No,
it's not. It's not realistic financially. I understand that. But, I know of patients who were, this kid was 25 years old. It was a hospital in a different state. I won't say what state or where it was. 25 years old. It was during H1N1. Had ARDS secondary to it. They didn't have ECMO capability. I knew that patient could be 25 years old, could have been saved were it not for, if you had ECMO, they beat him and beat him and beat him with the vent until his lungs finally turned to mush and he ended up passing.
But
That's wrong.
But can I tell you something? I'm going to be controversial back. ARDS did not develop in the 1 hour. That went on for days. You know
Of
that?
course.
Yeah.
Yes, I agree with that too.
They had the chance leading up to this situation. We always talked in our panels. When you think of ECMO, call for it. When you think of ECMO, don't ponder. Call for it.
Well, what do you say to the people who say ECMO doesn't save anybody? What about the people that take the CESAR trial and say that it was a poorly designed trial? The data's wrong because that shows 60% survivability for VV ECMO for ARDS, and they don't believe. They basically take it, tear it up, throw it out, say I don't believe it, and I'm not going to use ECMO.
I think the answer to that is two answers. The new data that's going to be published is going to blow them out of the water, especially with new diseases like coronavirus and what's going on with the flu. You know how many deaths from the flu this year?
Probably quite a few.
10,000.
10,000, yeah.
Yeah, we think corona's bad. The regular flu was 10,000. So we're ignoring these numbers.
Yeah, and that is an issue because everybody's talking about, what is it, COVID-19, coronavirus, whatever you want to call it, making a big deal out of it, and it's a big deal. Not saying it's not a big deal, it's a big scary deal. But, we have this other problem that's a lot more common.
That we can protect ourselves by just getting vaccine. I'll tell you, those numbers are going to blow everything out of the water. And you have to think of yourself, if you had the flu, do you really think you don't want to go on ECMO or not? So all these naysayers have to look at that. Mm-hmm. And, something like the flu is supportive care. For a few days, you should recover okay.
You should, I agree. And I've seen it.
Absolutely.
I've seen it, but there are still those people who will say, you put him on ECMO, he didn't really need to be on ECMO, that patient would have done fine without it. There are those people that will say that.
Okay, I'm going to talk about myself. Don't put me on ECMO if I'm far gone, but put me on ECMO early. Don't wait to beat me up with the vent and pressors and then put me on ECMO. I'm going to fail for sure.
Exactly.
Yeah.
Exactly. I agree. And then they do put those very same naysayers will do that, cause all kinds of barotrauma to the lung, cause all kinds of perfusion deficits to your peripheral microcirculation, brain, heart, liver, everything else, then put you on ECMO at the very end, and then you don't survive, and they say, see, the ECMO doesn't work. Look, you can't tell me you have never seen that happen.
For sure, I've seen that happen, and that's why I'm a big advocate. You think of ECMO, do it. And that's why I believe in ECLS for transplant patients. Again, this hospital I talk about, the nurses are trained. Transplant patients don't call the co-team, call the ECMO team. ECMO team comes, there's no even discussion. Okay, this patient was a transplant, can you relate? Either peripherally or Australia, zip the chest, can you centrally, put them on ECMO, and then ponder later. Was it a PE? And all this, or QT, all these things that we come up with, and then decide to go from there.
Yeah,
And
I
those
would agree
patients
with that.
recover and they get decannulated much earlier.
Yes, especially, and they just had a transplant. I mean, they should be fine. It's usually going to be something that is either fixable or convert them to a long-term VAD. Maybe they had some kind of, graft failure that just occurred for some reason, and they may benefit from another graft.
I'll tell you, me and one of my close friends, we something like that, put the patient on ECMO, list of 1A, and then figure out the solution in the middle. If the patient recovered, then you can take the listing off. You know what I'm saying? Find what the problem is, but don't wait, ponder. Like one of my good cardiologists say, don't have a journal club. Journal club with somebody's life is not a good thing.
Exactly.
For me, decide or don't decide, do it or don't do it.
Exactly. Yeah, don't wait.
No,
The longer you wait, the less chance you have to survive.
absolutely. You're just wasting somebody's brain, kidneys.
I thought Stephanie was going to call. Can you, oh no, she's doing a case. I forgot. She's doing a heart. She can't call. She was going to call. Okay. So do you guys want to take another 5-minute break before I wrap up with mine?
Yeah, we can do, you want to do 5 or 7?
7 minutes. Okay. 10-minute break, everybody. We'll take 10 minutes and we'll see you right back. I've got a real interesting talk about the soul, and we're going to bring Tracy Howarth back, and she's going to participate in this panel discussion. I think you're going to find it very interesting.
Do you have a
I'm gonna
soul?
talk up. That hurt. We're going to talk about some ancient Egyptian beliefs, and it's going to be a little lighthearted. It's not going to be as intense as this, but got a caller. Who called? You have to answer it. Hello, you're on the air. Hello? Oh, that hurt.
Hello?
Hello? Hey, you're on the air. Who's this?
Hey, it's Stephanie.
Hey,
How are
Stephanie,
you
I was just
guys?
talking about you. Stephanie,
I
your
know,
girlfriend
I
called.
was going to call in, but you guys had so much to say. I thought you were doing great on your own.
Thank you.
Stephanie, where are you? I missed you here.
Oh, I have just pulled into the hospital. I am about to start a pericardial window.
Good luck, Stephanie. I hope it's a simple
miss-
window.
Thank you.
With no holes in the heart.
I miss... no holes. I appreciate your talk, guys. And I guess my thoughts, real quickly, are it doesn't really matter, I think, to me, what the circuit design is. I mean, we can always start working on improving that as well. We just need to focus on, for transport, the weight of the pump and our footprint. So the way we're okay with our SCPC pump, but I would like to have something that was cost effective, but also weighed a little less. And then I've also I think we've done a good job on decreasing footprint by doing things like now we I don't know if you guys will agree with this, but we lay the oxygenator on the patient and tape it to them so that we don't have the hardware for that and the extra weight. Couple of things I think also that would be beneficial that we don't do, and I just want your thoughts on it. I think we should create a go bag so that when it's time to transport, we have everything we need and we're not thinking last minute, like, what should we take with us? And then also, I just am wondering what you guys think about, we don't actually usually bring a backup circuit, and should we be doing that? Or do you think with an hour transport, that would just be, if something really catastrophic happened, would we be able to get another circuit up and running,
I think a go back is amazing. That's an amazing idea. That's the other circuit. I'll let Joe answer that.
I don't
Okay.
I don't think I would even want to try to change a circuit in an ambulance. I think
I agree with that. It would be too cumbersome, and there's so
It
many
would
things
be
that
a
come-
nightmare.
yes. I don't.
But
I
are we
don't.
liable, if we don't bring one, and if something breaks, that we don't try?
This is true, but if something breaks, my suspicion is that there's an old saying: the best way to get yourself out of trouble is to not get in trouble in the first place. And so I would
Agreed,
say,
100%.
I would say don't break anything. Because I don't think it's, if something was that bad, I don't think there'd be enough space and time and organization to be able to do it. I think it'd be just a disaster. I think either way it'd be a
It
disaster.
probably would.
Yeah.
I think
I was just throwing it out there.
But I think the
thinking,
go bag-
how can we do better?
the go bag makes a lot of sense. I like that idea. You like that
Absolutely.
idea too.
Absolutely.
And I think we could do
I
a
like
better
that.
job with that. Have that already prepared.
Right.
Yes.
Agreed. Okay, guys, I'm walking in, so you're doing a great
Good
job.
luck, ma'am.
Thank you. Have fun.
Thank you. Have
Bye.
a good day.
All right, bye. Oh, good. So she called because she loves you.
Thank you.
Okay,
I
she
feel
wanted
it.
to be here, but she knew she had this case that she had to do and she couldn't be here.
Absolutely.